One of the current biological theories about the etiology or cause of OCD is the role of neurotransmitters. The history of this theory actually goes back to the 1960s. At this point in time, most psychiatric clinicians had a theoretical foundation in psychodynamics. There were no drug treatments for OCD, and standard treatment was the interpretation of dreams and getting into the roots of unconscious conflicts. So a Spanish psychiatrist, Lopez Ibor, was testing a drug for depression that was hoped to be a better antidepressant compared to what was currently available. It turned out that it wasn't a superior antidepressant, but some of the patients were reporting a reduction in obsessive-compulsive symptoms. So this was a serendipitous observation and discovery, because this drug, called clomipramine, affected the availability of serotonin. Antidepressants at the time affected the availability of a different neurotransmitter, noradrenaline. So the fact that people with OCD who were given clomipramine showed improvement, but people given other antidepressants didn't show an improvement, gave rise to the serotonin hypothesis for OCD. So the serotonin hypothesis suggests that the symptoms of OCD are due to a dysfunction in the neurotransmitter system. It is believed that low levels of serotonin cause the neurotransmitters receptors for serotonin to become hypersensitive. That is, lower than normal levels of serotonin cause an abnormal increase in the number of receptors, and so the neurons react too easily to the presence of any serotonin. So how does the lack of serotonin affect OCD symptoms? One theory is that the serotonergic system modulates the function of the orbitofrontal cortex, which is involved in learning and behavioral flexibility. The excitability of the neurons means that activity occurs without external stimulus, and that the neural network gets stuck in a pattern of activity and is unable to switch to a different pattern. This results in intrusive and obsessive thoughts, and results in deficits with reversal learning, task switching, and attention shifting. However, almost 40%, a bit less than half, of patients don't respond to treatments that target serotonin. Another neurotransmitter that may be involved is dopamine. Dopamine is associated with Tourette's syndrome, and OCD and Tourette's often occur together. Additionally, patients treated with medications targeting the dopamine system show an improvement in OCD symptoms. It is known that dopamine and serotonin also interact in the basal ganglia, which is a part of the brain that is implicated in OCD. It has been shown that a lowered level of dopamine, but not serotonin, in the caudate nucleus impairs performance in reversal learning. Lowered levels of dopamine in the orbitofrontal cortex lead to impaired extinction. Another theory is that an excess of glutamate is a contributor to the development of OCD, and evidence for which is an increase in glutamate in patients with OCD and a correlation between glutamate levels and symptom severity. Genes that have been associated with OCD are also associated with decreased expression of glutamate transporters. These are the parts of a neuron that are responsible for the reuptake or mopping up of excess neurotransmitters. So a decrease in the number of glutamate transporters therefore means an increased level of glutamate. Although an initial weakness in the neurotransmitter theories was their foundation on correlational studies, later work using transgenic animals has shown that changing the expression of genes associated with neurotransmitter expression are related to the expression of OCD-like behaviors. Of course, it is not possible to tell if an animal really has OCD, so OCD-like behaviors is defined in terms of excessive grooming and anxiety. One possibility being considered is that OCD is a multidimensional condition, and each dimension has its own set of symptoms and its own etiology. As usual, more work is needed to elucidate the etiology and pathology of OCD.